This is day 4.
4.5. So anyway, coming to this problem, this is I don't know, in our setup this seems to be a common problem, common enough problem. I mean about 25-30% of cases when we do and who are already sick, Intermax 3, IABP before transplant, these are common problem. So acute renal dysfunction, significant problem post-transplant, CKD incidence is 11% at 5 years. Now beyond that, there is a lot of now studies showing patient is on CNI, there is a CKD continuous incidence at 5 years, 11%. Of course, non-nephrotoxic immunosuppressant drugs are available like mTOR inhibitors, IL-2, of course, basiliximab, ATG prior to this, and now the newer small molecules, of course, Dr. Jignesh would know more about it, the JAK and elaticept, that's the future that will come. So the one important clinical problem what we face the post-operative period, as even our cardiac Prabhat Suresh would agree, is that slippery triad of infection, rejection and this renal dysfunction. This is a common problem. This is where we have to dance, in the post-op period. It's a big headache. And beyond now, what are the causes of early renal dysfunction? The first few 15 days. One is of course PGD, it's CHF and reduced cardiac output, right ventricular failure with any reason, cardio-renal syndrome. Cardio-renal syndrome, like in the previous case, the Jignesh could be a very important contributory factor, and if you can correct it in some way, your creatinine and renal function would improve. Now, high levels of CNI drugs. This is another important thing. There are some people, now we do this metabolic testing, I see very commonly. There are some few cases, not all, who are very sensitive to CNI. Suddenly the level jumps up, and these are the people whose creatinine might go up. High sensitivity to CNI, and rejection, of course, related ventricular dysfunction. And acute, of course, this tacrolimus related. You introduce tacrolimus, there is a toxicity, which some of the cases are reversible due to reduced renal blood flow, and the late ones like other mechanisms which has been described for this is RAS activation, endothelial dysfunction, tubular injury, etc. The late phase, if you get some of them go for a chronic renal dysfunction, or people who go for chronic renal dysfunction, they have this chronic afferent arterial vasoconstriction, fibrogenic mediators, tubular atrophy, etc. These mechanisms, especially in patients with hypertension, diabetes, would lead to a chronic nephrotoxicity. Now coming down to the individual susceptibility mechanism, what are the mechanisms? So there are some patients who have a particular susceptibility to calcineurin nephrotoxicity, and the evidence, there are now some studies which show that systemic levels may not be that important in such case. Might be local levels of kidney or renal tissue calcineurin, like CNA levels related to P glycoprotein and other polymorphisms in all these areas, CYP, ABCB, etc. Another important is of course the pharmacokinetic variability. Age, older age also contributes to CNA toxicity. Now there are various studies which are earlier ones, landmark ones from Hunt, Gustafson and Stipman, etc., which have shown earlier that there could be an improvement or renal dysfunction or improvement in creatinine levels if you give a calcineurin-free environment. Like Gustafson in 2007 demonstrated renal recovery from CNA-induced CKD with sirolimus-based immunosuppression. Hunt similar papers from Vienna and Munich. Stipman, their paper also shows the same switch if you do from CNI to everolimus. This was another study, Nocte study from Scandinavian study, which randomized 282 patients on maintenance who were on after thoracic transplant, 190 heart, 22 lungs. So they basically had everolimus introduction with CNI reduction, one group, or standard CNI, and they measured the GFR at baseline at 1 year. And again, it shows that more than I think there was improvement in this everolimus group of GFR as such. The beneficial effect was sustained beyond it. The scheduled trial was another trial in AJT which was published, almost the same result, in which it shows that improvement, better GFR on the everolimus group. And the biopsy proved acute rejection of 2R and almost same, and CAV was less in the everolimus study, everolimus arm. Another study we showed the same. then this is one study which of course Dr. Patel would be very familiar, Aisen and Kobashigawa. This is a large trial, 721 multicentric trial, in which interestingly patients were randomized to one group. First group was everolimus at 1.5 or 3, higher dose, and reduced dose cyclosporin versus the standard one, myfortic standard dose cyclosporin, steroid and induction. Cyclosporin dose here was interestingly reduced after 1 month. So 1 month it was maintained. And then the endpoints were biopsy-proved rejection, acute AMR with hemodynamic compromise, retransplant death. These were the endpoints. And it was shown that everolimus arm was not inferior to the other group at 12 months and 14 months. And everolimus 1.5 milligram with reduced dose cyclosporin, similar efficacy, but had reduced intimal proliferation by IVUS. And eGFR, of course, I don't know, at first 4 months or lower in the EVL arm, but later it picked up. So the early improvement in renal function after transplant diminished over time with everolimus at 1 milligram, but it was not inferior to the other arm. CMV infection was less in the everolimus group. So overall they showed a benefit of discontinuing cyclosporin at 1 month and beyond that changing to everolimus. So message from these trials is early CNS dose reduction. The first month itself results in greater renal benefit as the scheduled trial and the Aisen other trial. Late CNS withdrawal even till 5 years results in some benefit. Less CMV infection and CAV in the everolimus group. Increase in the bacterial infection possible in the AVL group. Biopsy proved incidence BPAR, biopsy proved acute rejection was same in both the groups. Now another interesting concept which we have at least we know about it is the CNA holiday. That means there are some, this come from the renal, basically renal transplant, in which a temporary CNA holiday reported from a single center renal transplant patients, in which there were CNA therapy was replaced by basiliximab and afterwards, that means given at day 1, 4 and 20 days, and afterwards every 7 days. So they couldn't introduce CNA, resulted in no acute rejection and later improvement in the renal function. So we have now certain situations in which we are just unable to introduce tacrolimus. So the tacrolimus, of course, is less vasoconstrictive effect compared to cyclosporin, less late fibrosis, less blood pressure, etc. But diabetes, tremors, etc. higher. CSA risk cyclosporin is higher. Vasoconstriction, blood pressure effect, hirsutism, etc. Comparing these two CNS. Now, if you have mTOR, there are other side effects like acne, mouth ulcers, dyslipidemia, longer half-life, sirolimus, everolimus, myelosuppression, wound healing problem, etc. So now the other strategies, what would you do? In future, what are the other strategies? For a case in which prolonged there is a azotemia, you are unable to withdraw. Now, inhaled tacrolimus is another thing which has been in a few studies tried out for lung transplant cases. Other one is the cyclosporin nanoparticles with polylactide. And other thing is plan and titrate CNA, your CNA drug as per the CYP metabolizer status. This we are now doing it metabolizer status according to CYP polymorphism and find it very useful. The other strategies, if blood pressure is high, counteracting drugs, calcium channel blockers, ACE inhibitors, statin, etc. Avoid NSAID. These are the drug interactions of the CNA. There are some drugs which increase CNA levels, antifungal, macrolide, oral contraceptives. Important to remember. Some drugs which reduce CNA levels, rifampicin, nafcillin, etc. So in a given case, if now we have also just this year given an abstract to ISHLT from our 9 cases in which we just could not introduce CNA at 9 to 12 days, and we used everolimus. We used early everolimus strategy, and then at 0.25 milligram BD, and introduced a late CNA after 15 days at again low dose. So many of them got about 2 months of low dose everolimus, low dose cyclosporin, and at third or about third month we could then go back to full cyclosporin and avoid any azotemia. So I don't know, this is probably, I don't know whether you agree this is a good strategy, but it worked well in those cases. We didn't find even only one single case we had of increased pericardial efficiency, and there was no wound healing. I don't know, it was we submitted as an abstract to ISHLT. They didn't accept it, but I thought it was an interesting concept which worked well for us. So now I think over to you for discussion and any questions.
Sir, why not only 3 drug, and you should have continued everolimus with MMF and steroid? Why low dose of tacrolimus and low dose of
So a couple of issues with PSIs. On their own, they don't really have an adverse nephrotoxic effect, other than the fact that there is an increased risk of developing proteinuria. So we always monitor these patients for proteinuria, because when you get it, it becomes problematic. Now, the Save the Nephron study was performed several years ago. It was one of the first studies to look at a CNI-free regimen early, and it did show an increased risk for rejection and mortality when everolimus was used early post-transplant.
As a renal transplant.
Yeah, no, in heart transplantation.